The ability to classify and diagnose disorders has its advantages, as it allows doctors to communicate more effectively about a patient and use similar terminology when discussing them. In addition, they can then predict the outcome of the disorder and suggest related treatment to help the patient, such as specific drugs and therapies. Diagnosis of schizophrenia is difficult as the practitioner has no physical signs but only the symptoms the patient reports. The method of classifying of schizophrenia should be reliable. Reliability is the extent to which a finding is consistent. In order for a classification system to be reliable, it should be repeatable. Different clinicians using the same system, for example the DSM, should arrive at the same diagnosis for the same individual. Clinicians should be able to reach the same conclusions at two different points in time, known as test-retest reliability, or different clinicians must reach the same conclusions when presented with the same patient, inter-rater reliability. Cohen's kappa coefficient is a statistic which measures inter-rater agreement for qualitative items. A kappa score of 0.7 or above is generally considered good. Validity is the extent to which we are measuring what we are intending to measure. For example, a test of intelligence should measure intelligence and not something else, such as memory. The validity of schizophrenia as a single disorder is questioned by many. Are we really testing what we think we are testing? In the USA, only 20% of psychiatric patients were classed as having schizophrenia in 1930. But this rose to 80% in 1950. In London, the rate remained at 20%, suggesting that neither group had a valid definition of schizophrenia. In fact, neuropsychologist Michael Foster Green suggests that neurocognitive deficits in basic functions such as memory, attention, central executive and problem-solving skills may combine to have an outcome which we are labeling schizophrenia, as if it was the cause when in fact it is simply an umbrella term for a set of effects. Schizophrenia is further complicated by overlapping symptoms and comorbidity. Many symptoms of schizophrenia are also found in other psychiatric disorders. For example, people with dissociative identity disorder actually have more schizophrenic symptoms than people diagnosed as schizophrenia. Most people diagnosed with schizophrenia could also receive at least one other diagnosis. Comorbidity describes people who suffer from two or more mental disorders. For example, schizophrenia and depression are often found together. This makes it more difficult to confidently diagnose schizophrenia. For example, a psychologist called Buckley estimated that comorbid depression occurs in 50% of patients. 47% have comorbid substance abuse. Another study found 12% of patients with schizophrenia also fulfilled the diagnostic criteria for OCD. Comorbidity occurs because the symptoms of different disorders overlap. For example, major depression and schizophrenia both involve very low levels of motivation. This creates problems of reliability. Does the low motivation reflect depression or schizophrenia, or both? It has also been pointed out that a diagnosis can have many adverse effects, such as a self-fulfilling prophecy. In other words, patients may begin to act how they are expected to act and develop lower self-esteem. So, how exactly does all of this affect a diagnosis of schizophrenia? Schizophrenia diagnosis research suggests there is a significant difference between countries when it comes to diagnosing schizophrenia. In other words, culture can affect diagnosis. In 1971, American psychologist Copeland gave 134 US and 194 British psychiatrists a description of a patient. He found 69% of the US psychiatrists diagnosed the patient with schizophrenia compared to only 2% of the British psychiatrists. This suggests current methods of identifying schizophrenia may be unreliable as they are not producing the same results when repeated across different cultures. It has also been found that hearing voices can be affected by culture. In 2015, Lerman interviewed 60 adults with schizophrenia, 20 from Ghana, 20 from India and 20 from the United States. Many of the African and Indian subjects reported positive experiences with the voices. They said that the voices were playful or provided advice. Not one American reported the voices as positive. The voices were violent and hateful, they said nasty things. The individual saw them as a sign that they were ill. Furthermore, gender can affect diagnosis. In 1970, Braverman found clinicians in the US equated mentally healthy adult behavior with a mentally healthy male. For this reason, women were perceived as less mentally healthy and were more likely to be diagnosed. Even more worryingly, studies have found that even the gender of the psychiatrist themselves can also affect diagnosis. In 1988, Loring and Powell randomly selected 290 male and female psychiatrists to read 2 case vignettes of patient behavior. When the patients were described as male or given no gender description, 56% of psychiatrists diagnosed them with schizophrenia. If they were described as female, 20% gave a diagnosis. This gender bias was not evident among female psychiatrists. This suggests the diagnosis is influenced not only by the gender of the patient but also the gender of the clinician. Studies have shown that the inter-rater reliability for the diagnosis of schizophrenia is generally astoundingly low. A 2001 study by Whaley found inter-rater reliability to be as low as 0.11. Further problems of inter-rater reliability are highlighted in the Rose and Hahn study where mentally healthy individuals were falsely diagnosed in U.S. psychiatric hospitals. There is still a lot of disagreement and errors made when diagnosing schizophrenia. This suggests the underlying criteria may need to be improved. One example of a criterion which may not be useful is criterion A, symptoms. This is because only one of the characteristic symptoms are required if delusions are bizarre. When 50 senior U.S. psychiatrists were asked to differentiate between bizarre and non-bizarre delusions, their inter-rater reliability was 0.4. Even this central diagnostic requirement lacks sufficient reliability for it to be used as a method of distinguishing between schizophrenic and non-schizophrenic. Therefore, the wrong diagnosis may be made as this characteristic is heavily subject to different interpretations.